Hello, my name is Tabitha Wedham, RN BSN with the University of Hartford, Nursing 621. This is my change project, Food as Medicine and Orthopedic Surgery. House Bill 5337, an introduction. This bill wants to assemble a task force to expand nutritional assistance and incentivize healthier eating across Connecticut. The bill would like to cultivate healthier eating habits, translating into healthier future generations. It will increase nutritional consumption of healthy food and economically support local farmers by bringing their products to market, as well as combat food insecurity, assisting individuals that do not have readily accessible healthy food due to financial barriers. And finally, to decrease prevalence and severity of disease perpetuated by poor nutrition. This is the current timeline for House Bill 5337. It is entitled An Act Concerning a Food as Medicine Task Force and Healthy Eating Incentives, sponsored by the Human Services Committee and introduced on March 3, 2022. Unfortunately, the current bill died in chamber April 4, 2022. Reasonings are because increased collaboration is needed for a more efficient path forward, as well as many members opposing requiring Head Start and early childhood centers to host hours for the WIC program. However, this bill is highly supported by Connecticut health departments, the Department of Agriculture, university nutrition programs, and Hartford Healthcare. The plan to reintroduce this bill will come after more work and collaboration has been done. My thesis statement: a comprehensive nutrition plan supported by nurses throughout the orthopedic surgical continuum of care may optimize patient health, reduce recovery time, and improve patient-reported outcomes. My change project idea is to integrate food as medicine and orthopedic surgery. I'd like to institute a comprehensive nurse-driven nutrition assessment and recovery plan spanning the orthopedic surgical continuum. Learning objectives. Number 1, learn how malnutrition places patients at risk during and after orthopedic surgery. Understand evidence behind nutrition in Enhanced Recovery After Surgery, or ERAS, guidelines. Appreciate the multidisciplinary approach to patient surgical optimization. Understand the importance of education materials to support change. And finally, to learn how to measure and sustain a change such as this. Malnutrition in the surgical cascade. Malnutrition places patients preoperatively and postoperatively at an increased length of stay in the hospital. They have higher rates of readmission. They have higher mortality rates. And for the elderly, a rapid deconditioning of cardiovascular health, followed by decreased functional strength and lower independence. The surgical cascade. Surgery stimulates a cascade of inflammatory, immune, and metabolic responses. It's important to understand that this begins during surgery. There is an increased protein catabolism or breaking down of protein in the skeletal muscles. Insulin resistance increases and leading to hyperglycemia, a reduced protein synthesis, and all of this leaving our patients at risk for impaired wound healing. Loss of skeletal muscle mass happens over the next few weeks after surgery. For instance, after a total knee replacement, patients may lose 1% of their lean muscle mass per day for the first 2 weeks postoperatively. Without intervention, there could be an 18% muscle mass lost in the quadriceps and hamstrings alone in the first 6 weeks of surgery, which is problematic as mobility is medicine for our orthopedic patients. Enhanced recovery after surgery was first described by Danish surgeon Henrik Kaylet in 1997. The basic premise of this guideline is reduction of physiological and psychological stress from surgical intervention can lead to shorter recovery time and reduce financial burden. The preoperative recommendations of ERAS. The following slides will be from 2 studies, Hirsch et al. 2021, as well as Kay et al. In 2019. Preoperative assessment for malnutrition. This should include nutrition labs and nutrition consults as necessary, intervening prior to surgery. 7 to 10 days prior to surgery, there should be optimal nourishment prior to surgery. Nurses should emphasize complex carbohydrates, fresh produce, fiber, and protein intake of 1.2 to 2 grams per kilo per day. It is important that the day before surgery, our patients do not arrive to pre-op completely hungry and famished. Patients should be encouraged to eat high-quality protein and carbohydrate-rich meals about 6 hours before surgery. Upon arrival to pre-op and 2 hours prior to surgery, patients should have a clear 8 to 10 ounce beverage that contains 50 grams of glucose. Intraoperative stress state. The ERAS protocol is aimed to decrease psychological and physiological stress, and this begins in surgery. Optimizing nutritional status all the way to 2 hours before surgery supports nutritional needs during surgical stress, reduces insulin resistance, and protects lean body mass. The goal of intraoperative care is to reduce surgical stress, maintaining normal thermia, minimally invasive technique, spinal anesthesia or nerve blocks, and optimal fluid balance. The postoperative recommendations include resuming oral intake as soon as possible after surgery. This would include 50 grams of glucose as soon as the patient is awake. 30 grams of protein as their appetite recovers, which could be through a protein shake or through a small meal, and returning to solid food within 24 hours, with at least one meal having 30 grams of protein. 12 weeks of recovery plan. Patients need to consume 1.6 to 3 grams per kilogram per day of protein. They should consume high-quality complex carbohydrates. We need to encourage them to drink protein drinks, especially when they have a low appetite. Educating our patients to eat meals about 3 hours before their rehab exercises, and recovery protein drinks after exercise or physical therapy. I would like to make the following changes to our surgical nutrition guidelines for our orthopedic population in my hospital. We already do a nice job optimizing our patients preoperatively, but I would make the following changes. Adding a pre-op nutrition education plan to our virtual patient engagement platform. During pre-surgery consultation, give a copy of our nutrition education plan as well as a tracking chart to our patients. The reason for the duplication is for our patients who are not computer savvy and are not engaged in our virtual platform. Change the NPO instructions to no solid food for 8 hours instead of it being no solid food after midnight. This is to benefit our patients who are scheduled for surgery much later in the day so that they are not having such a long time between their meals. Upon arrival to pre-op, giving each patient 50 grams of a clear glucose drink prior to going into surgery. Post-operative optimization, I would also like to provide a clear glucose drink of 50 grams of glucose in PACU once the patients are ready to drink. Scheduling a protein drink every 8 hours in the hospital for every patient, not just those who are identified as nutritional risks or malnourished. And sending 3 protein drinks home at transition with instructions for the patients to consume them the following day. And then adding a 12-week post-op nutrition plan and tracking sheet to our after-visit summary, as well as Force Therapeutics, our virtual patient engagement platform. As part of my change project, nursing and patient support would be vital. Nursing education would include 2 education modules covering the ERAS guidelines as well as a new nutrition program. I would utilize our current HealthStream program and audit compliance by shadowing pre-op discussions and shadowing discharge teaching on the floor. And then this would require re-educating nurses as necessary based on what I would find. Patient support is of most importance. Pre- and post-operative education would require written and virtual with our Force Therapeutics program, as well as our nurse navigator support. They would need weekly nutrition tracking sheets and case management consults for those who need to utilize state and federal programs for nutrition support as needed. Current programs could include the Connecticut House Bill 5337, if it's passed as discussed previously, as well as the federal nutrition programs through the Older Americans Act of 1965. The training and teaching resources would include patient preoperative education about the basics of nutrition, how nutrition helps them heal after surgery, and a nutrition plan for 2 weeks before surgery. Postoperatively, giving our patients a basic physiology of healing after surgery and the risks of malnutrition, as well as a 12-week nutrition plan and tracking sheet. For our bedside staff and nursing staff, helping them understand the science behind surgical stress, nutrition, and the human body. Enhancing recovery after surgery education, new nutrition program, the interventions, and the bedside nursing role. I would like to present the following budget for my change project. On any given fiscal year, there are 7,000 orthopedic surgeries at my institution. The pre-op clear carbohydrate drink has a cost of $3.18 per drink. Protein recovery drinks are approximately $2.68, leading to a total cost of $157,000. Cost for staff education. There are 3 educators who would work approximately 20 hours creating education modules and supporting the nursing staff, as well as about 100 staff members who would need to complete a 1-hour education module. Staff wages would approximate $7,600 in cost. For other materials, the staff education could happen on HealthStream, which is already purchased by the institution and would lead to no further cost. Patient handouts in the after visit summaries and in our pre-surgery appointments, about 2 sheets of paper leading to 28 reams of paper and $108 in cost. Now, the patient education materials on our virtual platform, Force Therapeutics, would not increase the cost that is already put into that platform. Total cost for my project, $164,791. Now, while the cost of the program may seem quite high, let's look at the cost savings that could potentially happen from this project. The average cost savings per orthopedic patient is $180 for those who are nutritionally optimized prior to surgery, according to Hirsch et al. 2021. This can decrease length of stay and decrease readmission rates. Now, taking my 7,000 patients at the institution and multiplying that by $180, that is $1.26 million in savings. Subtracting the cost of the program, the possible cost savings is $1,095,209. Key stakeholders for this project include surgeons and nursing leadership, the anesthesia providers, frontline providers including nurses and nutritionists, and of course, patients and their caregivers who will be responsible for their nutrition plan both preoperatively and postoperatively. Implementation timeline for this project would include pitching the project to present the change idea to our surgeons, anesthesia providers, and the nursing leadership. Once it was approved, creating the education. In collaboration with nutritionists and anesthesia providers, create education for patients and frontline staff. When we are ready to go, gathering our resources, collaborating with nutritionists, operations leadership, and kitchen, choosing and ordering the recovery drinks. And then providing education, set a go-live date and give the education created, and then audit compliance. Once we are going, auditing and collecting data would be extremely important. Auditing the implementation at the various stages and monitoring patient success and outcomes. My plan to maintain interest and support for this program would include sharing our success and involving bedside caregivers in our research accolades, advertising our success to Greater Hartford, adding job roles for nurses at all education levels, nutritionists, and researchers, offering yearly education modules, as well as ongoing research to optimize patient recovery, improve patient outcomes, and decrease the episode cost of care. Measuring the success of this program would include watching our postoperative patient-reported outcomes at 12 weeks, watching our patient satisfaction surveys through Press Ganey and Force Therapeutics, trending our physical therapy tests, including the timed up and go and our 30-second sit to stand, trending length of stay in the hospital, and trending our ED visits and readmissions. Key points for my presentation. House Bill 5337, once it's passed, will be a beneficial bill creating a task force to enhance nutrition in Connecticut. Patients who are optimized with nutrition recover more quickly and have fewer adverse outcomes. Implementing a nutrition program requires collaboration of a multidisciplinary team. And communication success through data and ongoing research will help maintain interest and support of this program. Here are the references that I utilized. Thank you so much.